Introduction. The article presents a case study focusing on a 7-month-old poodle who experienced complications following the removal of an atlantoaxial implant. Atlantoaxial instability, a condition frequently seen in young, small dog breeds, occurs due to issues like congenital dens hypoplasia, fractures, or ligament problems. This instability can lead to a range of symptoms, from neck pain to paralysis, depending on the severity of the spinal cord injury. Surgical intervention is often needed for patients with neurological issues or severe pain that doesn't respond to other treatments. Ventral stabilization techniques are often preferred due to better visualization of the atlantoaxial junction, fewer complications, and reduced need for additional surgeries. However, complication rates can be quite high, between 33 and 53%, and can include issues like coughing, laryngeal paralysis, and Horner's syndrome, often caused by accidental damage to nearby structures. Such complications may necessitate further surgery, such as revision or explantation. While these complications have been noted in human medicine, particularly during revision surgery, the specific causes and management strategies, especially after explantation, are not well defined in veterinary medicine. This case report seeks to explore these complications, specifically focusing on damage to the vagosympathetic trunk and recurrent laryngeal nerve, along with the deformity in the retropharyngeal space, following the removal of the atlantoaxial implant using a ventral approach. The paper will discuss the clinical course of the patient and the management of these complications. Study design, case report. This study is structured as a case report, detailing the clinical journey of a single canine patient. The patient, a 7-month-old neutered male poodle, initially underwent ventral stabilization surgery to address atlantoaxial instability, which was causing severe neck pain. 1 year later, the dog began experiencing severe coughing and vomiting. Radiographs revealed that the atlantoaxial implant had loosened and was compressing nearby structures, including the upper esophagus and airway, necessitating removal of the implant. Following the explantation surgery, though the initial compression symptoms were resolved, new significant complications arose, including dyspnea, dysphagia, and dysphonia. To evaluate these issues, various diagnostic methods were employed, including physical examinations, blood work, radiography, contrast fluoroscopy, rigid endoscopy, and computed tomography imaging. The patient was treated with a variety of methods including tracheostomy and gastrostomy tubes, nebulized saline, amoxicillin clavulanate, and meropetant. The progress was monitored through repeated examinations and imaging, allowing the clinicians to record how the dog responded to the interventions over time. This detailed approach enables a thorough analysis of the causes and management of these post-surgical issues. Results. The dog's clinical journey involved several stages, which were thoroughly recorded in the study. Initially, 1 year after the ventral stabilization surgery, the dog presented with a severe cough and vomiting. Radiographs, as shown in Figure 1, clearly illustrated the failure of the implant. Panel A depicts a right lateral view of the cervical spine, while Panel B shows a ventrodorsal view, both revealing the screw loosening and compression of adjacent structures. The arrows in the figure highlight the areas of implant failure. Following the implant explantation, the initial symptoms were resolved, but the dog then developed severe dyspnea, dysphagia, and dysphonia. Examination revealed meiosis in the right eye and hyperemia of the right ear pinna, as seen in Figure 2. In Panel A, the meiosis of the right eye is noticeable, while Panel B shows the right ear pinna as hyperemic and warmer compared to the left. These signs suggested partial Horner's syndrome. Contrast fluoroscopy revealed a delayed swallowing reflex with leakage of contrast into the trachea, as shown in Figure 3A, and rigid endoscopy confirmed reduced movement and hyperemia of the right laryngeal cartilage, indicating right-sided laryngeal paralysis as seen in Figure 3B. In Panel A of Figure 3, the fluoroscopic image shows contrast material in the proximal portion of the trachea, and in Panel B, the rigid endoscopy reveals decreased movement of the right laryngeal cartilage. Computed tomography on postoperative day 15 revealed a retropharyngeal space deformity measuring 11.9 by 8.9 by 6.1 mm, as shown in Figure 4A. This space was located ventral to the vertebral body of the second cervical vertebra, also known as C2. On postoperative day 104, A subsequent CT scan showed a reduction in this retropharyngeal space to 8.1 by 5.5 by 3.4 mm as seen in Figure 4b. The management of the complications involved supportive measures. The patient received a tracheostomy to alleviate dyspnea and a gastrostomy tube to assist with enteral feeding. Nebulized saline and antibiotics were administered to address aspiration pneumonia. The patient was fed a liquid diet through the gastrostomy tube multiple times a day. By postoperative day 6, the aspiration pneumonia had improved, and the hyperemia in the right ear had resolved. The tracheostomy tube was removed on day 12, dyspnea having resolved. By day 16, the anisocoria had improved, and the patient began to vocalize with improvement in dysphonia. By day 37, the patient's voice fully recovered, swallowing function was confirmed by fluoroscopy, and the gastrostomy tube was removed. The patient was successfully discharged. Follow-up CT scans after discharge showed the retropharyngeal space had decreased in size. The patient remained healthy for over 18 months post-discharge, without recurrence of dyspnea, dysphagia, dysphonia, or Horner's syndrome. Discussion. The discussion section of the article delves into the significance of the reported findings and their implications for veterinary medicine. The authors begin by noting that the ventral approach is a common surgical technique for atlantoaxial instability, but neurological damage is a known complication, typically arising within 48 hours of the procedure. Such damage can lead to symptoms like dyspnea, laryngeal paralysis, and Horner's syndrome, and in severe cases, respiratory failure or cardiac arrest. The risk of neurological damage is higher during revision procedures for anterior cervical spine surgery, which is consistent with what is seen in human medicine. However, there are no optimal management strategies for complications related to the ventral approach for atlantoaxial implant explantation previously reported in veterinary medicine, making this case important to document. In this particular case, the dog developed dyspnea, dysphagia, and dysphonia due to right recurrent laryngeal nerve paralysis as well as right-sided Horner's syndrome, all caused by damage to the vagosympathetic trunk and the recurrent laryngeal nerve during implant explantation. The recurrent laryngeal nerve, a branch of the vagus nerve, provides sensory, motor, and parasympathetic fibers to the larynx. Paralysis of this nerve is a common complication following cervical spine surgery, especially with anterior approaches to the neck due to the nerve's proximity to the esophagus and trachea. Surgical trauma, especially during retraction of the larynx and trachea, can easily injure the nerve. In human medicine, recurrent laryngeal nerve paralysis is quite common, with incidence rates varying from 0.2 to 24.2%. Horner's syndrome, resulting from dysfunction of the oculosympathetic pathway, is less common. This pathway involves neurons that extend from the hypothalamus to the spinal cord, then travel through the thorax and cervical region, and finally to the orbit. This syndrome's low incidence, especially in veterinary practice, is possibly because the vagosympathetic trunk is situated laterally and dorsally to the recurrent laryngeal nerve, making it somewhat protected during surgery. The patient's right-sided Horner's syndrome was attributed to the injury of the right vagosympathetic trunk during the surgical explantation. The authors speculate that the surgeon's right-handedness led to an approach slightly off the midline, which may have contributed to the nerve damage. This lateral approach increased the risk of Horner's syndrome due to displacement of the sympathetic trunk from the midline. The right recurrent laryngeal nerve is also more variable in course and branching patterns compared to the left, making it more susceptible to injury. Misidentification of the branches innervating the trachea, esophagus, or inferior constrictor muscles can also result in iatrogenic injury. Therefore, a careful understanding of neuroanatomy is essential for predicting and preventing nerve injuries during surgery. Despite the nerve damage, the patient showed a full recovery after about 37 days of symptomatic treatment. This aligns with previous research showing that nerve damage that is not due to compression or transection is often reversible, and usually recovers in about 1 month. A similar case involving cranial nerve injuries showed full recovery within a month of revision surgery, and studies on trigeminal neuropathy indicated an average recovery time of about 22 days. The study also reported the formation of a retropharyngeal space as a post-surgical complication, which, to the best of the author's knowledge, has not been reported previously in veterinary medicine after ventral cervical approaches. While pharyngeal diverticula have been documented in human medicine as complications, occurring approximately 1.6% of the time, they are mostly asymptomatic. These diverticula are typically diagnosed through contrast fluoroscopy or CT, revealing a lateral pharyngeal pouch. Although dysphagia was observed in this patient, it is attributed more to the recurrent laryngeal nerve paralysis than to the retropharyngeal space, as fluoroscopy did not show any retention of contrast within the space. The case study highlights that, while dysphagia is a documented complication of ventral approach surgery, it can rarely arise from large pharyngeal diverticula. The authors recommend that if dysphagia continues beyond 3 weeks, the possibility of a pharyngeal diverticulum should be assessed. Finally, it was observed that there was no recurrence of clinical signs related to the atlantoaxial instability after implant removal. The authors hypothesized that the formation of fibrous tissue around the atlantoaxial joint during the patient's growth may have contributed to the joint's stability after the initial surgery, allowing for a successful recovery after the explantation. The study concludes that a thorough comprehension of neuroanatomy is crucial for preventing nerve injuries. If nerve damage occurs but is reversible, approximately 1 month of supportive care is generally adequate for patient recovery. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.